discuss about the ventilatory targets.
Yeah.
Thank you.
Thank you, Mauro. Thank you all. There will be, I can jump on the small part on oxygen, despite I don't have the same enthusiasm of Rafa for these papers, I have to be honest, but they still can give some information. So we talk more in general about the ventilatory settings that we can and we should use in acute brain injured patients. The reason why it is more difficult to ventilate these patients is a bit what our colleague was telling us in her first talk. After the initial traumatic brain injured patients, there is a cascade of events. I joke with my fellow because when they call me and they say, Chiara, there is an isolated TBI, I always say isolated TBI does not exist. And I mean that every time there is an initial brain injury, then from a systemic inflammation, then you have, from a local inflammation, you get then a systemic inflammation which make the peripheral organ very susceptible for complications. And the brain and the lung are exactly the two types of organ which basically go into different directions because the inflammatory mediators caused by the TBI can affect the lung, but if we are not good at ventilating the lungs, the bar trauma and the actelic trauma that we create, that we give, can create itself the release of inflammatory mediators. And then we should not forget that when we treat one of these two organs, we do a damage to the other. If we, for example, we use barbiturates, hypothermia, etc., these are all factors which can increase the risk of pulmonary infection. When we do induce hypertension, sometimes we give too many fluids in patients with TBI. These are all factors which can directly affect the lung function. I really like this experimental study because I think it really makes us understand the pathophysiology. This is an experimental study which was made on pigs, and these were randomized. They was divided in groups, control, patients so without ARDS, with healthy lung, patients with induced ARDS, and in both the groups, intracranial hypertension was induced. And the results of this experimental study, in my opinion, are very interesting because regardless the initial presence of a lung injury and ARDS, the induced hypertension increased the amount of extra lung water. So there was a direct effect, alveolar effect of damage at the level of a barrier of a lung. If we translate this in the clinical practice, we know that brain-injured patients have a very high risk of pulmonary complications. This is a very recent meta-analysis which explored the incidence and the effect on outcome of ARDS in this population. There is a pooled incidence of 20%, but if we split the incidence in before 2011 and after 2011, there is a huge difference. In the last 10 years, the incidence of ARDS is importantly reduced, and I'm going to explain you why in a few slides. When it happens, anyway, regardless the timing, regardless it happened before or after 2011, it is importantly associated with worse mortality and worse neurological outcome. So why is it a problem, an additional problem in these patients? Because, as Raphael was saying, we are in a situation where we have two organs to be protected. And at the end, what we aim with mechanical ventilation is to provide enough oxygen to the brain. And, but we don't know how much is enough. When I was in Cambridge, we did this physiological study. It is a retrospective analysis of values of cerebral oxygenation compared to systemic oxygenation, and we found that already with a PEF value below 310, you have several episodes of cerebral saturation. Now, if you look at our patients in the ICU, I think that in my units, the 80% won't have a PEF higher than 310. So we have to ventilate a patient with a lung that had a first hit, and despite this, I have to ventilate him properly because I need to provide appropriate oxygen to the brain. How can I do it? Unfortunately, brain-injured patients have always been excluded by the largest randomized control trial, which explored the role of lung protective ventilation because of concern on the ICP. But what we know from the general ICU population is that if we are not protective on the lung, we increase the risk of mortality. And this has been demonstrated both in ARDS and in non-ARDS patients. This is the adjusted probability of hospital mortality at the increase of a driving pressure. And you see there is a linear, huge, very steep correlation. And there is a linear correlation also with the plateau pressure. So in theory, we should apply also this concept to the brain-injured patients. But there is a problem. The problem is that we have an injured brain. So if we, for example, have a brain which is swollen, so we have already compression of the venulas and of the venous sanus, everything that we do and that increases the intrathoracic pressure can reduce the outflow at the level of the jugular level. So it can increase the cerebral edema. So that's why these patients were excluded from the trials of lung protective ventilation. And on the other hand, if I do, I don't know, a recruitment maneuver, or if I use the PEEP, I might increase the intrathoracic pressure, and this can have an effect on the hemodynamic status and therefore reduce the cerebral perfusion pressure. So it's very difficult, but there is another problem. You know that in the general ICU we use low tidal volumes and we allow CO2 to go up as long as the pH is fine. It is the permissive hypercapnia. We can't do this in brain-injured patients because if the CO2 goes up, what happens is that we have a cerebral vasodilation, which can increase the intracranial pressure. Also, if you remember the guidelines for the CO2, for the ICP control, there are specific targets of CO2 which have to be taken in account and have to be achieved. So we had fun some years ago with my group of Genova and my boss, Professor Pelosi, to describe the 10 false beliefs about the mechanical ventilation in brain-injured patients. Because what we realized is that until 10 years ago, these patients were ventilated with principles that are completely opposite to the principle of a general ICU population. They used to be ventilated with a very high tidal volume. They used to be ventilated with a very high respiratory rate to reduce the CO2, to control the CO2. The PEEP was scaring, so ZIP in most of the situation. Recruitment maneuver were absolutely forbidden. Prone position was absolutely forbidden. ECMO was, TBI was considered an exclusion criteria. Now, why we are calling these false beliefs? Because what we are learning from the general ICU population and what we are applying even in this population are making us understand that it is true that these two organs go into different directions and have probably different targets, but it's not completely like this. This is one of the few, actually it's the only prospective study which assesses the effect of driving pressure in a population of acute brain-injured patients. High number of patients, observational study, so with its limitation. Driving pressure was independently associated with the development of ARDS and with the increase of mortality. So the same as for the general ARDS and non-ARDS ICU population. Last year, with my group, we did this sub-analysis on post-anoxic cardiac arrest patients. It's a sub-analysis of nearly 2,000 patients, and we assessed the effect of different ventilatory settings and strategies on outcome. And we found that some of these settings, like driving pressure, mechanical power, and respiratory rate were independently associated with 6 months mortality and neurological outcome. And then we had a very tough reviewer who asked us to apply a formula, which is this one. It is called the Costa formula, which was applied in the ARDS population and had showed to be more importantly associated with outcome than mechanical power itself, and that seems in the ARDS population to be the real marker of lung damage. We applied it, and I have to be honest, it was right, because as you can see here, the effect on mortality of this formula, so of the driving pressure and the respiratory rate itself, are much more strongly associated with the mortality. So, from these studies, what we are understanding is that probably we have to be protective even with the lung of brain-injured patients. And it's something that physicians are understanding, because this is a survey of the European Society of Intensive Care that we did 3 years ago. Eduardo Piccetti asked to the responders, would you be scared in case of ARDS to use high PEEP? And no, the response was no. Would you be scared to use low tidal volume in this population? No, the important is to keep a low plateau pressure. Would you be scared to use any of the rescue strategies that so far have been importantly challenged in this population? Well, look, I was very surprised that in 70% of the responders, they would use recruitment maneuver. In 47%, they would use also veno-venous ECMO, and prone position in 63% of the patients, despite we don't have any evidence. This is a study that we did with a Spanish group, and this describes exactly what I was telling you. In 2004, the median tidal volume used in this population was around 9 milliliter per kilo of predicted body weight, but importantly, 1/3 of these patients in 2009 were ventilated with more than 12 milliliter per kilo of predicted body weights. It's a lot. In 2016, only the 9% of these patients were ventilated with a very high tidal volume. Same for the PEEP. In 2004, 1/3 of the patients were ventilated with ZIP, so with 0 PEEP. And in 2016, they were only the 8%, still a lot, were ventilated with a ZIP. So a few years ago, we decided to put down a panel of experts trying to give some recommendations on mechanical ventilation, and we try to go through all the parts of the management of mechanical ventilation in this population. And if you see here, the expert obtain a strong agreement regarding the fact that, especially when you don't have a clinically significant ICP elevation, so when ICP is anyway under control, you should use lung protective strategies. No consensus was obtained when you have an ICP which is very unstable, but we'll discuss it in the last part of my presentation. PEEP, we should use, according to the expert, the same level of PEEP that is used in the general ICU population, but especially we should abandon the ZIP, because this causes actually trauma and a lot of damage. And this is the study that you showed before. I have the luck to work with a group, a very strong respiratory group, and they do the quantitative computed tomography study, which is the gold standard to assess the recruitment of the lung through the segmentation. And I applied this in brain-injured patients, and in reality, the point is that if you set the PEEP in a way that it causes good recruitment, does not cause alveolar hyperdistension, does not cause hemodynamic instability, you don't have a detrimental effect on the ICP. So it's safe as long as you are very precise and consider the respiratory and the cerebral mechanics. Regarding the targets, I think that Rafael discussed already the point of the targets of oxygen. This is a very nice study from the Center TBI, which demonstrated that hyperoxemia can be associated with worse outcome and increases it's also associated with an increases of the cerebral biomarkers. We, in our practice, tend to keep these patients with very high PaO2. The median PaO2 in the Center TBI study was around 130, the median. And then we tend to reduce it during the ICU stay. But this is probably not enough, because this is the effect of hyperoxemia according to the days of ICU admission, and the major effect of hyperoxemia is mainly in the first day and in the first part. Now, in the consensus, we set a threshold of 80 to 120, and as Rafa showed, this cannot be absolutely simple. What I think is important of this paper is not the number itself, is that we have to start to think that each type of brain injury has different needs. So we need to start to individualize the target according to the needs. And if you look at, these are all the different types of brain injury, there is a much narrower and clearer U-shaped curve in ischemic stroke. So probably those patients who have a higher risk of ischemic area might be more susceptible to the changes of the oxygen. CO2, we know that there is a long story regarding hyperventilation in TBI. Hyperventilation has been initially challenged because of studies like this, which demonstrated that hyperventilation can reduce the cerebral blood flow. But now there are more recent studies which demonstrate that a mild, moderate, and for not too much time hyperventilation can be actually safe. And in fact, hyperventilation, what we found in this sub-analysis of a center TBI is that there is heterogeneity, but it's used very, very often. The median values of PCO2 in this population was around 34 millimeters of mercury. And if you see these are the Seattle guidelines. We have specific threshold and target of CO2 that needs to be achieved according to the tier that we use. As tier 1 is 35, 38. As tier 2, we have to achieve 32 to 35 millimeters of mercury, but not below. So in conclusion, in terms of ventilatory strategies in brain-injured patients, I will say that if ICP is not too unstable, we have to apply exactly the principle that we use in the general ICU population. And even strategies like recruitment maneuver or prone position can be considered as well as ECMO or extracorporeal support. The problem is the problem is when we have a concomitance of ARDS and intracranial hypertension. So we have just written this editorial, which basically considers in a pragmatic way and gives suggestions. It is done with Luigi Camporota and Giuseppe Citerio, and gives suggestions about which strategies to use according to the levels of intracranial hypertension and to the severity of ARDS. And the general principles, which relies on this seems complex figure, but it's not, is that we have to be ready to step the stairs of the staircase approach of ARDS and of the management of intracranial hypertension. Thank you.